Hello dear patients and our followers. I'm Dr. Ahmedov, hair transplant surgeon from Smile Hair Clinic. Today we are going to do a small brief evaluation of the patient who underwent a hair transplantation surgery in our clinic almost 14 months ago. This is a 29-year-old white male with the mixed type of the hair loss. Every once in a while, most of the time when we share the cases with you, we tell that's the neurotype 5, neurotype 4, neuro 6, 7, so on so far. But there is also a portion of the patient or part of the patient that may have a mixed type of the hair loss. What does it mean? It means that the front area of the hairline has a different type of the grade of the hair loss, and the crown area may have a different grade of the hair loss. So the patient had a mixed type of the hair loss. It means the front line is mostly close to the neurotype 2 to the 3, and the crown area is close to neurotype 4V. V means the vertex of the crown area. For the neurotype 2 to neurotype 3 type of the patients, on average we may need the numbers varying between 1,800 to 2,500 grafts. A crown area or neurotype 4V, or the crown area where the size of the crown area may be more than 40 or 50 centimeters squares as a size, we may need something between like 1,200 to 1,800 grafts for the crown area. So combined for this mixed type of the hair transplant surgery, we do the calculation separately. An average number of the grafts we need for the front side and the number of the grafts we need for the crown area. So the patient was as a mixed type of the hair loss, neurotype 2 to 3 in the front side, and as I've told, neurotype 4V to the crown area. We did a rough estimation of the number of the grafts to be between 3,600 to 4,000 grafts on average. The plan was the reconstruction of the front hairline, covering the temples, reinforcing the front forelock, and increasing overall density and coverage of the crown area. As you can see from the pictures, neurotype 2 to neurotype 3 means the receding of the front hairline and asymmetric hair loss of the temples, losing of the density and the volume in the front forelock, and maybe some degree of the hair loss in the front third of the hair. And in the crown area, we have the crown area that is in the size of 45 centimeters squares with areas of hair loss and miniaturization of the hair. The patient was transplanted in total 3,900 grafts. 2,050 of them were used in the front for the reconstruction of the front hairline and covered the temples, and 1,850 grafts were used in the crown area with the rough density of 35 to 40 grafts per centimeter square. But it's not only the area that there was the hair loss. During the surgery, we used the special surgical loops. And with surgical loops, if we see during the surgery that there are some small empty spots in between the other areas, we make the transition between the hair loss area and the transition in between the normal areas of the hair. So here we can see the result of the patient 14 months after the hair transplantation surgery. The priority was, as we have told before, the reconstruction of the front hairline. When we do the reconstruction of the front hairline, there is a thumb up rule number 1. The hairline should be conservative. It is slightly as high as possible and slightly narrow to the corner, so it gives us the chance to give the patient more coverage and the density. One more advantage of the higher hairline, it means that using a lower number of the grafts, and it means preserving the donor area for the future surgeries just in case if the patient will need. And finally, the hairline has a tendency of receding over the years. So when we are 20, our hairline is really low. But as we men specifically get older, our hairlines recede. This is called the maturation of the hairline. So the hairline, 20-year-old boy, gentleman, and 40-year-old man are really different. So adjusting the hairline, keeping the hairline slightly higher or conservative also gives us the chance so the hairline will be actual for the rest of the life of the patient. So we don't want the patient who will be in his 40s, 50s be with the hairline of the boy who is in his 20s. And one more thing is that if just in case there will be some receding of the hairline, and you won't end up with an island of the hair here, empty spots to the corner or to the upper side of the hair. So we have caught up our desired priority to reconstruct the front hairline. The hairline looks really major with the sharps with more acute angles that are mostly seen in the male type or masculine type of the hairline. Also, the corner is one of the pitfalls that we see during the hair transplantation surgery, the transition from the front side to the temple, or as we call the frontal temporal transition or frontal temporal angle. It has been adjusted really nice, so it's really hard to say whether the patient had the surgery or not. So the good surgery is an unnoticeable surgery. And also we can see the crown area. It has been covered. There are almost no visible empty spots. So it's a good example on how the hair transplantation surgery can dramatically change the life quality of the patient, his or her outlook. Also, we advise the patient to seek out with the medical treatment. It can be finasteride, minoxidil, or combination of both of them. Most of the time, we also get the question from the patient saying, okay, whether they will need the medical treatment or no. Where most of the time for the patient with androgenetic alopecia, we advise the medical treatment. Why? It's like a puzzle. You have the hair loss, and as I also said, we fit it in or do the transplantation according to the hair loss pattern you have today. But if all the time your non-transplant hair continue to shed, we may end up with new empty spots. So surgery is mostly needed to cover the open areas as much as possible, and the medical treatment is needed to prevent furthermore loss of non-transplanted hair. So they actually should complete each other. Thanks for watching us and stay tuned.